Of course, there are three major toxicities. One is the cytokine release syndrome, which occurs usually early, and then the neurotoxicity, ICANS, which also occurs sometimes in conjunction with the CRS or alone. And the third problem is the long-term toxicity in terms of cytopenias, which has been identified by many colleagues as the main reason for non-therapy related death. Approximately almost 50% of the deaths in patients in remission occur through, or long-term toxicity occur through these infections, for instance. And so some of these problems may be directly related to lymphodepletion. Yeah, so we have data on fludarabine cyclophosphamide that if you increase the dose, you increase the efficacy, but you increase the toxicity. That's pretty clear. So there we can play with the dose, and it also seems that there is a critical threshold, but we don't know the actual threshold in the individual patient, so to speak. So there's a problem. But if we knew that, we could probably avoid some of the toxicity problems. And then the other novel development is that there is increasing evidence that Bendamustine, for instance, will really have the same efficacy in terms of outcome of these patients, but it will decrease the severity and number of CRS and the severity and number of ICANS. And also, in addition, it is associated with a much faster recovery of neutrophil cells, meaning that the infections will be less, and that's been shown. And that also, for instance, the hospital stay of patients will be decreased. So I think we can influence the toxicity by choosing the right lymphodepletion to a certain degree.